This lecture will cover a variety of theories useful for pediatric occupational therapy practice. The majority of the theories in this are not necessarily specific OT theories. Some will be general OT theories applied to pediatric practice, and some of the theories will be accessed from other disciplines such as psychology or development. The first theory that we'll cover is a review of the person-environment-occupation theory, also called PEO. This theory is a general occupational therapy theory that can help you organize information as you are reviewing cases. This theory really focuses on the overlap between person factors, environmental factors, and the specific occupation being assessed. The greater the overlap in the fit between all of these three areas, the better occupational performance a person can experience. You will be asked during cases throughout this course to utilize PEO as a way to organize case information and determine what further information you may want to acquire during your evaluation process. SI theory, or sensory integration theory, was developed beginning in the late 1960s and early 1970s by Dr. Jane Eyre. She was an occupational therapist who worked with kids with developmental delays. Very simply, sensory integration can be described as organizing sensory input for use. Our senses give us information about the physical conditions of our body and the environment around us. Countless bits of sensory information enter our brain at every moment. Think about the 5 senses that you learned about probably as a child. In addition to those 5 main senses of sight, hearing, taste, smell, and touch, you also have vestibular and proprioception systems. You can see these at the bottom of the pyramid on the slide. These sensory systems provide information to the brain about a child's environment or body and helps them feel safe and secure about what's going on around them. The brain must organize all these sensations into logical information about their environment. Sensory integration puts all these pieces together. An adaptive response is a purposeful or goal-directed response to a sensory experience. This is the output related to sensory information provided to the brain. For example, when a baby sees a rattle, they may reach for it. Reaching is an adaptive response. Merely waving the hands aimlessly is not adaptive. Adaptive responses are purposeful and goal-directed. Adaptive responses are developed through sensory motor play. You can see in the pyramid on the screen that each level of development builds on the previous section. Therefore, it would make sense that if one of your sensory systems is not providing accurate information to the brain, the development related to motor planning, body scheme, or body awareness could significantly be delayed. Additionally, higher level perceptual motor skills such as language skills, visual perceptual skills, focus and attention, and eye control would significantly be delayed if anything below that area has been delayed. Many of the occupations that we discuss or talk about for pediatric practice include development of self-care skills or ADLs, different behavioral responses, behavior management, and academic learning, as school is a major occupation of children. These, as you can see in the pyramid, all depend on appropriate and effective sensory integration on the early levels. NDT, or neurodevelopmental treatment, is another theory useful in pediatric practice. It's a holistic approach to improving movement patterns in clients with tonal differences due to neurological injuries such as cerebral palsy or stroke. Evidence shows that the best outcomes for NDT, especially for children with cerebral palsy, are when the therapy is provided early on in the developmental phase of normal movement patterns before abnormal movement patterns can take over. So this would make a case for birth to 3 therapists working with children with cerebral palsy or other tonal differences using NDT as an approach in birth to 3 services. As a child, for example, is beginning to learn how to walk, that the therapist could be providing NDT treatment to make sure that gait pattern is occurring in a normal preferred movement pattern rather than developing abnormal movements. NDT is built on the concepts of inhibition and facilitation. So inhibition is decreasing those abnormal movement patterns and using facilitation to increase the desired movement patterns. The main therapeutic tool in NDT is handling. That is, that the therapist is using their own body and arms and hands to use key points of control. Key points of control allow the therapist to control the client's whole body in order to guide them through movement patterns. This occurs while the client is moving actively, also through the movement patterns. We recommend NDT certification if this is a tool that you are planning on using frequently in your practice. Handling techniques can be complex, and especially advanced techniques, you would want to have advanced continued education. A very useful theory comes from the field of psychology. This is Piaget's developmental cognitive theory. In this theory, Piaget describes the process by which individuals develop their thinking processes. This is very important for occupational therapists to consider because no matter what skill we might be working on, whether it's primarily a physical impairment, self-cares, or an academic piece, how we would approach intervention for that child will depend on what cognitive level they're at. And so remember, just like in our typical developmental milestone, kids with disabilities may not be where their chronological age says they should be, and similarly, our kids with disabilities may not be in the chronological cognitive stage that they should be in for their age. So to be able to assess how are they processing and learning is really critical when we're looking at providing interventions for children. So the first stage of cognitive development in Piaget's theory is the sensory motor stage. In typical development, this runs from birth to around 2 years old. In this stage, infants are really only aware of what's immediately in front of them. They interact with their environment in a physical way by putting things in their mouth, holding onto things, kicking things. They don't know how things will react, so they're constantly experimenting with activities like shaking, throwing, again, chewing. They really learn through their world with trial and error. Around 7 to 9 months, typically children begin to realize that objects exist even if they don't see them. This milestone is called object permanence and is an important cognitive milestone to indicate that memory is developing. This can be a red flag to look out for children with disabilities if they are not developing object permanence. That's a huge red flag for intellectual disabilities. Once an infant starts crawling, standing, and walking, their physical mobility can lead to increased cognitive development because they have extra access to environments. So they get another level of what's on top of the couch or what they can see. They can move to different areas, and so they will have a boom in cognitive development. Early language development, typically occurring between 18 and 24 months, are also a sign of typical cognitive development, that kids are beginning to understand a little bit of symbolic relationship, that these sounds that I make come out of my mouth actually have a meaning and mean something to other people. Around age 2, kids move into the pre-operational stage of cognitive development. This happens between age 2 and 7. So think about preschoolers. In this stage, young children are starting to think about things symbolically. Their language should develop and become more mature. They also develop memory, imagination, and begin to play pretend. Their thinking is really self-centered and based on their own emotions and often very illogical. Kids in this stage typically cannot grasp complex time such as detailed cause and effect, time, or comparisons and contrasting. As children begin the age where they would move into elementary school, it's between 7 years old and 11 years old, is the concrete operational stage of cognitive development. In this time, children begin to demonstrate logical and concrete reasoning. The connection between if, then becomes very specific for them. Things tend to be very black and white or right and wrong. Kids also become less egocentric and are increasingly aware of events happening outside of themselves. They start to realize that their own thoughts and feelings may be unique, and that they are not necessarily the thoughts and feelings of those around them. They still cannot really think abstractly or do in-depth hypothesizing. Starting in adolescence, around age 12 or 13, children are able to use symbols to relate to concepts. This is why algebra can be taught to that teenage group. They also start to think about multiple variables and how one situation could have multiple outcomes and start problem solving through how would you get the outcome that you want. This stage is also very kids begin developing those concepts like justice, equality, fairness, some of those more abstract pieces, and start to struggle through what do those mean and what's my place in helping some of those things happen. Piaget did believe in lifelong intellectual development, but he insisted that the formal operational stage is the final part of cognitive development. In order to continue intellectual development, adolescents and adults depend on accumulation of knowledge from a variety of sources. Vygotsky also provided us a very useful framework for considering how much support a child needs. Again, the zones of proximal development theory is also from the field of psychology. Vygotsky talked about how much help an individual might need in order to gain new skills. So you can see in this picture, the purple circle is the current area that maybe a child already has mastered. It's a mastered skill. They can be 100% independent. Everything outside of that purple circle would be things that he or she hasn't achieved yet. So those could be all learning tasks, fine motor skills. But think about from a developmental aspect, everything outside the purple is developmental milestones that they have not achieved yet. Now, there are some of those developmental milestones that would be totally out of reach. No matter how much help they need or receive, they're not going to get those at this moment. So you can see on this diagram, that's the lime green area, that out of reach. But there's a whole middle area that kids could participate in or could learn and start figuring out how to do those tasks through a process called scaffolding. Think about scaffolding on a building as it's being built. It's an external support that helps keep things stable while the building is being constructed. In a similar way, scaffolding in Vygotsky's theory is the external support of an adult, a teacher, a therapist, or parent that helps provide stability to the child while they are learning a new task. So anything that the child can learn with some scaffolding would be within that child's zone of proximal development. So it's the developmental pieces that are next to their current developmental area. This is really important to think about when we're providing intervention, when we're developing goals for our children. We want to make sure that what we are setting them up for is not in that out of reach zone. We want to look at creating the just right challenge. And so using this idea of zone of proximal development and identifying what they're already mastered and what the next steps would be is very helpful in our intervention planning as occupational therapists. Another helpful theory for pediatric practice is Bandura's social learning theory. This is another theory that helps add to our understanding about how individuals learn. This can become very important in our intervention planning. Bandura suggests that individuals can learn through observing others. This is why methods of peer modeling, video modeling, and social skills training using other peers is a big component of what we do in pediatrics. Our final theory in this lecture is Maslow's hierarchy of needs. Again, this comes from the field of psychology. This is one of my personal favorites. Maslow's hierarchy of needs really helps us think about a person from a holistic viewpoint. And the whole premise of this is that items that you see on the bottom of the pyramid must be in place before someone can focus on something higher in the pyramid. For our clients, we need to make sure that they're getting their other needs met before we're asking them to learn a new skill or a new task. Their energies and focus are not going to be in a place that is optimal for learning if, for example, their physiological needs aren't met. So the bottom level of the hierarchy is physiological needs. These are things like water, food, shelter, even sleep. We've seen this affect kids, for example, at school if they come from a family where they're not able to access breakfast in the morning, or if they sometimes kids with new siblings and the babies are up and they're all sharing a room and they're not getting good sleep. Not having those physiological needs met significantly impacts the ability of the child to focus at school. The next level is safety, and this is not just physical safety, although that is part of it, but it also is, stability in the family, mental health safety. So if a child's being teased or picked on or emotionally abused somehow, that is also going to indicate that this level of need is not being met. So in order for a child to, again, focus on learning or therapy or play, they need to feel safe and secure in whatever environment they are in. Sometimes we have very limited control over safety. That's issues happening in the home, but we can make sure that our clinical or our school settings are safe and have a feeling of safety about them. The third level, excuse me, the third level is loving and belonging, or also it's been called acceptance. For this level, really focuses on the relationships between the individual and the people around them. So for babies, might look like secure attachment to parents. It can be friendships as the child is growing older, or family relationships. And into the teens, it can be romantic relationships. So if there are significant relational problems happening for an individual, that's going to redirect their focus and energy off the learning as well. Once an individual has physiological safety and acceptance in their life, then they move on to the fourth level, which is self-esteem and confidence. This is shown by respecting others and also by being respected. This is a sense of self-worth. And as individuals develop this, and we see this fairly early on in kids, as they're developing this, they are eager to be moving towards self-actualization. So self-actualization is a very lofty concept. Maslow himself said that less than 5% of the population will actually reach true self-actualization. But the motivation to move towards full potential is what working towards self-actualization is. So as a person is feeling good about themselves, getting their needs met, they will look for learning, for expanding their current knowledge base, for doing new things, for helping others, and that is part of self-actualization. So our goal is to help our clients feel safe, to make sure they're accessing resources to get physiological needs met if they are not, to help with social skills, or see if there is any kind of relational pieces that need to be addressed, and then helping them move forward in learning and building skills.